Yeah, as the next present, I would like to call upon the next presenter of the Young Physicians Forum, Dr. Aisha Jawardana, Senior Registrar and Veterinary Medicine, Professional Hospital for Respiratory Disease Lecturer. She'll be talking to us about necrotizing pneumonia, a step beyond pneumonia. Over to you, Aisha.
Very much, sir, for your kind introduction. Today, I'm going to discuss a rarely discussed topic among adult pulmonology, necrotizing pneumonia, a step beyond pneumonia. So let's begin. Today, within next 30 minutes, I am going to discuss about the definition of necrotizing pneumonia, differences between lung abscess, necrotizing pneumonia, and pulmonary gangrene, pathophysiology, clinical features, diagnostic evaluation, management, and disease outcome. Let me start with two of our patients which we have encountered during last year to create the interest in doing me this topic. This is my first patient, 67-year-old female who was previously healthy, presented with acute severe pneumonia. She had productive cough, rusty colored sputum, fever, loss of appetite, and malaise for 2 weeks duration. She had markedly elevated inflammatory markers, and her initial chest X-ray showed left upper zone abscess formation, but she was not responding to oral antibiotics, and her chest X-ray has progressed markedly within the course of the illness. The second patient was a young boy, 19 years old age, and he was previously healthy, again presented with a similar history within 1 week duration, but he has ended up with having type 1 acute respiratory failure with very high inflammatory markers. His initial chest X-ray, as you can see here, showed there is extensive right thorax consolidation. But despite of antibiotics, he progressed to have a lung abscess as well as pleural effusion. Let's start our discussion with pneumonia. Pneumonia, which is the inflammation of lung parenchyma, either can be infectious or non-infectious. Infectious pneumonias, bacterial pneumonia is the main part in it. So it can be community-acquired pneumonia or nosocomial pneumonia. So where does this necrotizing pneumonia falls here? It included in the bacterial pneumonia category. So by definition, actually there's no clear definition available, but the description explains lung parenchymal infection characterized by extensive consolidations, peripheral lung parenchymal necrosis, as well as multiple cavity formation. So as I have explained, it's a rare and severe complication of bacterial pneumonia. It is an extensive, rapidly progressive lung parenchymal injury with multiple cavity formation. The problem here is it causes loss of lung parenchyma and it carries higher morbidity as well as morbidity compared to simple community-acquired pneumonia. So these are the characteristic features. There is extensive inflammation and consolidation in the lung and parenchymal necrosis with multiple cavity formation. It's a spectrum of disease. Starting from lung abscess, then comes necrotizing pneumonia, and severe end is pulmonary gangrene. Let's see what lung abscess is. A lung abscess is a cavitary lesion filled with pus. Usually, it involves less than 50% of the affected pulmonary lobe. It usually starting with a consolidation, and the focus of pneumonia progresses to focal tissue necrosis within next 1 to 2 weeks, and then it gets walled off. And the characteristic feature is there's a thick fibrous capsule surrounding the abscess. And these patients has a prolonged course of symptoms and they have more systemic symptoms. Then comes to the next, necrotizing pneumonia. It shares similar but more extensive pathological process, poor perfusion and liquefactive necrosis of lung parenchyma, and multiple lung lobes are affected with more extensive parenchymal involvement. Multiple microabscesses are formed initially and then they coalesce together to form large cavities. And these cavities, unlike lung abscesses, they don't have surrounding capsules. Then pulmonary gangrene. It is more extensive lung necrosis, and it involves more than 50% of lung lobe, and there's thrombosis and in the small and large pulmonary vessels. Lung abscess, necrotizing pneumonia, and pulmonary gangrene often can coexist in the same patient. However, they are vaguely differentiated according to the degree of necrosis and radiological patterns, as well as disease severity. Pulmonary gangrene is not only caused by necrotizing pneumonia. There are several other causes like pulmonary embolism, neoplasm, trauma, surgery, and drug-induced and radiational injuries. But we don't categorize them as necrotizing pneumonia. However, the pathogenesis is very complex and poor the pathogenesis. One is lung parenchymal necrosis and due to vascular process triggered by an infection. Vasculitis, activation of the coagulation cascade, and thrombosis, and the end result is tissue ischemia. Bacterial toxins can directly damage lung cells and cause necrosis. And also the host response, intense cytokine-mediated inflammatory response, is again harmful to the lung. And there is liquid-active lung parenchymal necrosis, and then they form cavities. When the necrotic areas extend up to pleural surface, they cause many of the complications like parapneumonic effusions, empyema, pneumothorax, and bronchopleural fistula. Vascular thrombosis plays a major role here. It is important to mention about tissue factor, which is exposed after inflammation, and then it triggers a coagulation cascade. Therefore, vessels get thrombosed and the blood supply to the lung tissues is lost. However, there are several other factors which contribute to the disease severity, like host factors and pathogens factors. Therefore, only some get necrotizing pneumonia due to the same pathogen. However, there are some risk factors identified in some case series. The problem with this topic is the unavailability of high quality data available. But this literature is limited only to case series. They have identified similar risk associations like male gender, smoking, alcoholism, diabetes, chronic liver disease, and gastrectomy. Clinical features more or less the same as pneumonia. Patients present with productive cough, hemoptysis, fever, putrid breath, fluidic chest pain, and constitutional symptoms. But it is a more prolonged and protracted cause of illness. The complications are more common, like empyema, pneumothorax, life-threatening hemoptysis, bronchopleural fistula, and sepsis, septic shock. When it comes to the pathogens, there's a slight difference between lung abscesses and necrotizing pneumonia. Lung abscesses, more than 90% of the cases, they are polymicrobial in origin. But necrotizing pneumonia, there can be polymicrobial origin, but they have mostly a prominent pathogen, like Streptococcus pneumonia, Staphylococcus aureus, mainly PVL toxin producing forms, and Klebsiella, Haemophilus, Pseudomonas, E. coli, Acinetobacter, and rarely some mycobacterial species. What about post-viral conditions? This study demonstrated there was necrotizing pneumonia recognized in 4.5% of post-COVID patients, This was done during 2020 and 2021. However, this necrotizing pneumonia is not recognized as solely due to the COVID infection, but they have recognized secondary bacterial infection similar to other case series of necrotizing pneumonia. These patients had a higher mortality, about 71%. How do you diagnose necrotizing pneumonia? The problem with diagnosis is there's no clear definition, but contrast enhanced CT of the chest is the diagnostic modality of choice. What are the CT features? Necrotizing pneumonia patients will have consolidations which are very extensive, unlike simple pneumonia, and there will be poor or absent vascularity in the affected area. And the important thing is heterogeneous contrast enhancement in the lung parenchyma. And there will be air fluid filled cavities and air cushion sign in pulmonary gangrenes, mass within the mass site, which is described as necrotic debris within the pus-filled mass-like cavity. And there will be pleural thickening, pleural fibrous bands, and multisectations in empyema, and sometimes pneumatoceles. This picture shows a lung abscess. You can appreciate that it is a well-demarcated fluid-filled cavity with an air fluid level. This CT is typical of necrotizing pneumonia. There is complete collapse of lung, and you can see the upper part of the lung is very well enhancing, whereas the lower part is not, because it is necrotic. And the surrounding area, there is a large empyema. Pulmonary gangrene is more extensive disease. It involves more than 50% of the affected lobe, and this red color arrow shows the air cushion sign. It is not limited to fungal infections, as you all know. There's air filled area surrounding the necrotic matter in this necrotizing lung. How do you evaluate these patients? We should not forget that the patient should be evaluated as a whole. All systems should be evaluated, and we have to evaluate the patient's pathogen identification as well as anatomical evaluation with imaging. And we have to exclude the differential diagnosis by doing other cultures for TB, fungal infections, serum galactomannan, melioidosis antibodies, like things. And the immune status of the patient is again very important to be assessed by body mass index, blood sugar, liver, renal functions, HIV screening, and immunology where it is necessary. And we have to thoroughly consider about whether there is any occult focus of infection where the bacteria can come from the focus to the lung. So therefore, we have to do 2D echocardiogram to see whether there is infective endocarditis, intracardiac shunts, and ultrasound abdomen to see whether there is abdominal sepsis, and very important to examine patient's oral cavity to see the periodontal disease, dental abscesses, and look for skin sepsis, paranasal sinus infections, and patients should be evaluated for risk of aspirations. Some patients with neuromuscular disorders, GORD, and elderly patients are more prone to get aspirations, and aspiration is a common risk factor for lung infections. Etiological diagnosis we will have to do with non-invasive methods like sputum sampling as well as invasive methods. Invasive methods are important things are bronchoscopy and image-guided biopsy, image-guided aspirations of the pleural effusions, empyema, and lung abscesses. You can see in this picture, this is one of our patient's bronchoscopy image, how the thick purulent secretions are blocking the openings of the bronchi. So bronchoscopy is very useful in this type of very ill patients to obtain samples, accurate samples, because sputum samples can be misleading because they contain oral flora as well as upper airway colonizers. With bronchoscopy, we can go directly to the site of infection and take protected brush samples and bronchial washings and even biopsies for histological evaluation. And we also will be able to identify tumors, mucus plugging, or anything obstructing the bronchi. When it comes to the differential diagnosis, in our settings, tuberculosis is the first, and then comes fungal infections like invasive aspergillosis, mucormycosis, amyloidosis, cavitary lung malignancies, and granulomatous autoimmune diseases like ANCA vasculitis. This image shows in the left-hand side a TB cavity. You can appreciate there's dense surrounding plain bud opacities and well-demarcated cavity with lung volume loss and fibrosis as well. Fungal infection is shown in the right side of the picture. This again shows melioidosis, where there is multiple small lung abscesses and a malignant cavity which has a thick margin with irregular spiculated margin. The management of necrotizing infections is very challenging because there's no firm guidelines to suggest when to go along with medical management and when to go with surgical management. So the patient should be managed in a specialized center where thoracic surgical facilities are available. And we should have an aggressive approach to these patients' management. We should not delay any treatment. Medical management with antibiotics and supportive care is the mainstay of treatment. Early administration of appropriate empirical antibiotics, which are mainly broad spectrum, is needed in these patients. And they need more prolonged courses of antibiotics because the necrotic tissues lack the blood supply and the antibiotics don't properly deliver to the site. And antibiotics, unlike viable tissue, they don't penetrate in the necrotic areas. So, community-acquired pneumonia patients who have admitted to ICUs usually have a high mortality rates, and they deteriorate rapidly after initial resuscitation solely due to their disease progression. So, same appears in necrotizing pneumonia patients. Therefore, it is important to identify the pathogen in them. Antibiotics, we can't recommend this antibiotic to the, as a general term, but it depends on the local regional patterns and the patient's severity. Usually higher grades antibiotics with broad spectrum cover is needed. We should not forget about chest physiotherapy and postural drainage. It will help to drain your lung abscess. Now you can see in these images how the patients are positioned and to facilitate the drainage of secretions with postural drainage. Supportive care with respiratory support like invasive and non-invasive ventilation, oxygenation, mucolytic agents like carbocysteine, NAC, and hypertonic saline will be helpful to thin out the secretions and take out the necrotic parts. And we should not forget about nutrition, electrolytes, fluids, and comorbid conditions as well as DVT prophylaxis in these patients. Patients should be monitored carefully in HDO ICU setting, and they should be monitored for the development of new sites of infection because they can have bacterial seeding elsewhere in the body. Disease progression is monitored with repeat serial CTs because inadequate source control leads to progressive lung parenchymal infection, and CTs can identify necrotic blood supply, lack of blood supply early to identify pulmonary gangrene early. What is the role of surgery here? Actually, this is decided on individual basis. Not all patients need surgery. Optimum timing and indications are not clearly defined, and surgical risk is significantly elevated in these patients because they are hemodynamically compromised and they have lost a lot of their lung tissues as well. With surgery, we can do infection control with debridement of the necrotic tissue. It can be a wedge resection, segmentectomy, lobectomy, or pneumonectomy. And when there's poor response to antibiotics, surgery will be helpful. And when there's a lung gangrene, we need to dissect that part as well. empyema draining pleural effusions, management of pneumothorax, ungrowing the lung abscess, and re-expansion of the lung will be aided with surgeries. And it is very important to take some samples where the anatomical site is very difficult to be approached in other ways, where the surgeons can help us. However, you know about percutaneous drainage of the lung abscess with catheters, but this is not generally recommended in necrotizing infections because the catheter can get easily blocked with slough and necrotic debris, and will not drain the necrotic tissues, but only they drain collected fluid. And the problem is they can cause complications like iatrogenic empyema, pneumothorax, and also these catheters can damage normal viable lung tissue. Rehabilitation is again very important because they have lost a large volume of their lungs, so they are very breathless. So we have to help the patients with breathing exercises, physiotherapy, exercise training, and oxygen, nutrition, and psychological support, as well as immunization. What about the outcome? This Kaplan-Meier's graph shows that these patients have more length of hospital stay compared to normal community-acquired pneumonia. But mortality, there's no much of the data available, and mortality will be different according to the infecting pathogen. This study showed 42% mortality among patients who had necrotizing pneumonia secondary to Staphylococcus aureus. But we don't have our data in our country. Why do these people die? Actually, they mainly die due to respiratory failure, severe sepsis, massive hemoptysis, pneumothorax, and systemic septic embolization, ischemic events, venous thromboembolism, and aggravated inflammatory response in the host. With this background knowledge, we'll move into our two patients, whom I have mentioned previously. What was the outcome of our patients? The first patient, the lady with severe pneumonia, we could isolate coliform species from her sputum and bronchoscopy cultures. She was managed medically, mainly medically, completely medically, after having a multidisciplinary discussion. So you can see the progression of the chest X-ray. She was very well responded and cured. But the problem was the patient was having permanent residual lung damage. However, she needed a prolonged course of antibiotics, about 56 days, with piperacillin, clindamycin, and also coamoxiclav as oral treatment. What happened to our second patient, the young boy with severe necrotizing lung infection? Actually, we needed help of the surgeons to drain the empyema with IC drain, but he did not again go into further invasive surgeries. He also again managed with medical management prominently, and his sputum also positive for coliform species. Now you can see how he has healed at the end of the course of antibiotics. Now he is under physiotherapy and rehabilitation program, and he is doing well. So at the end of the lecture, I would like to emphasize that necrotizing pneumonia is a fatal disease, but it is curable, and the permanent lung damage is the problem here. Timely diagnosis and multidisciplinary approach are life-saving. These patients should be managed in an appropriate setting with aggressive management techniques, but overtreatment will result in more complications as well. Medical management remains the mainstay of the treatment, and surgery is carefully decided depending on the individual basis. These are my references. I would like to take this chance to thank my dear sir, my mentor, Dr. Eshan Pereira, consultant physician at NHRD Valisara, and my colleagues who had helped me, and my patients who gave the consent to give their details, and Ceylon College of Physicians for this wonderful opportunity. Thank you.
Thank you, Aisha. It's open for questions from the physical audience.
Because I mean, movies already, between the immunocompromised patient and the severe infection causing this. But, so it's important to recognize it very early. So are there sort of indicators that suggest that this patient may be developing necrotising pneumonia early on, so that you can, take necessary steps early on to prevent the development of necrotising pneumonia? That's one question. Another question is, can organizing pneumonia occur as pneumonia? That's the question I want.
With regards to early detection, actually these patients don't have any different symptoms. We go by the clinical history. They initially present as a usual community-acquired pneumonia. So with the time only, they get X-ray changes. I think the early suspecting feature is a development of small or lung cavities or abscesses, or progressive infiltration in the X-rays that we have to go by. Otherwise, we are not recommending doing CTs in all the patients, only where the patients are not responding to our usual management. We have to think about this disease entities. And the other question, organizing pneumonia, actually, if it is due to idiopathic causes, ILDs, there's no necrotizing pneumonia. And the other organizing pneumonias can occur due to infections like COVID. There are no directly causing necrotizing pneumonia. But the problem is they are more prone to get secondary infections due to inflammatory response and their altered physiology and anatomy. They are more prone to get these infections.
I have one question. Your two patients were positive for coliforms.
Yes.
We also do limit of coliform pneumonias coming into us also. Do you think it's probably secondary viral infection and leading to secondary bacterial, or it's just primary, pneumonia coming as coliform pneumonia?
I think the second one is more appropriate because these patients actually we have tested for COVID as well. They were negative and they didn't have any recent preceding infections suggestive of any viral infection. But I don't know about data. There may be a possibility, but in our patients didn't shown any evidence like that.
We use clindamycin also part of the treatment. Was it to have anaerobes? So because
yes, anaerobes can be underlying in necrotizing infections, but they are not generally considered as the main pathogen. But with severe infection, they contribute to the pathogenic process. That's why we selected that.
So those marks were sensitive to PFAS and
yes, yes.
Thank you.
Yes. Thank you very much for that excellent presentation. Are there any specific ultrasound features? Like, can we use inward ultrasound to monitor these patients?
No, sir.
Like COVID, we have special features. Like
no, not up to my knowledge. And empyema and things can be more prominent in necrotizing pneumonia patients rather than simple parapneumonic effusion. So we can see septated loculated effusions. Lung parenchyma wise, I'm not sure, sir.
The empyema that was passed there, or like you ultrasound you diagnose empyema there, or
there will be solid particles and thick appear ultrasonic features and septations.
Like was there frank pus? So
yes, there was frank pus. Yes.
Question from the virtual audience. Again on coliform, do we have any frequencies of worldwide figures at least of what are the common organisms which cause necrotizing pneumonia, or it's regional?
Yes, most commonly reported organism is Staphylococcus, mainly PV and toxin producing forms, but we have not isolated any in our patients. Worldwide data actually is limited to small case series, only including 4 or 5 patients. So, and case reports only. So, it is difficult to have an idea. But coliform is one of the reported causes, and for lung gangrene, mainly Klebsiella is recognized.
Any place for anticoagulation since there's vascular thrombosis involved in progression of the disease?
For the pathogenesis part, there's no evidence, but these patients, due to their higher inflammation and sepsis, they are more prone to get deep vein thrombosis. So we have to select carefully about anticoagulation in the form of DVT prophylaxis. But they are more at risk of hemoptysis as well, so we have to be vigilant.
Thank you, Aisha. So before we move to present I'd like to give certificate of appreciation on behalf of the Oncologist